Okay, this PowerPoint is over pleural effusion. What is a pleural effusion? It's simply stated fluid in the pleural space. And you can see on this slide the lung tissue, the chest wall there. You know that the pleural space is the space between the lung and the chest wall, and then you can see that the fluid has accumulated there in the left lung. Causes: heart failure, TB, pneumonia, pulmonary infections, PEs, or neoplasms can cause this. Assessment findings that you would see with large pleural effusions: you're going to see decreased breath sounds whenever you're listening to them. You're going to note dyspnea, orthopnea. And what is orthopnea? Need to make sure that you know the definition of that term. You're going to see coughing. A small pleural effusion may have no dyspnea or no pain. Large pleural effusions also usually have pain. Now, I'm not saying that small ones you won't see these symptoms, but usually it's a larger size pleural effusion before. This is a chest x-ray with a pleural effusion on the left side. You can see where the whiteout is, and that's the fluid. This is on a chest x-ray. Air shows up as black, and so that's why our lungs show up as black. And the other parts of our body that are denser are show up as white. This is a picture of a thoracentesis, the procedure that we do to remove that fluid. The fluid there has pushed this lady's lung up. We set them up on the side of the bed. We usually lean them on a bedside table, usually give them a pillow. We do continuous pulse ox monitoring, and the physician will come in, the nurse assists at the bedside, making sure that you're monitoring for vital signs and the patient stays stable, and the surgeon will just use a local, numb them up, insert the device into the pleural space, drain the fluid out, and normally it's just a small 4x4 folded over that they place over the puncture site whenever they go in to do this. And usually at the end, as you're getting close to draining all the fluid out, the patient will start to cough. So that's whenever you know that you're almost to the end of draining all of that fluid. And you try to keep them from coughing if at all possible, because that actually can cause a collapsed lung. So at that point, then you know that the fluid is almost done, and the surgeon will usually stop the procedure at that time. Other than doing the thoracentesis to remove the fluid, we obviously want to treat the underlying cause, whatever's causing our pleural effusion. We want to figure that out and fix it. In some cases, the patient may actually have to have a chest tube put in, and that's where we would just slide the tube in and actually leave it to re-expand the lung if it has collapsed, and drain all of that excess fluid out of there. So those are other options that you may see other than the thoracentesis.